sample of all deaths we knew about. Of 1,677 certificates inspected, the good news was that less than 10% had been certified to ill-defined conditions, but the bad news was that few doctors were documenting duration of illness, and many erred in recording the logical sequence of complications leading up to death. Now, I've run into a few persons at the meeting here who thought that I terrorized them when they were students. But some of it must have worked, as only 11% of the maternal death certificates lacked evidence of the fact of pregnancy, the first step in getting the certificate recognized as that of a maternal death. Over time, among the maternal deaths, we have seen improvements in the proportions of the deaths which have been registered and in the quality of their certification. The RGD, however, continues to let us down, and for 30 years they have only correctly accounted for 1 in 3 adequately certified maternal deaths through their coding practices. Based on this table, Jamaica has already achieved its Millennium Development Goal 5. Of 50 maternal deaths in 2008, the surveillance process identified 43 for a maternal mortality ratio of 101, missing 20% of direct deaths, particularly ectopic pregnancy deaths at home, but captured all of the indirect deaths. 68% were registered and certified as maternal, however, more than half of the indirect deaths had been poorly certified and would have been missed if they had been properly coded. Now, this is a medical certificate of an actual maternal death, and we're going to look at how these errors occur. Firstly, the pregnancy checkbox, which you can barely read because the font is so small, is often ignored. You should have a tick there, yes, if the death was pregnancy related. Also, of course, the duration of illness is not recorded. This information is then transcribed to something called a death registration form by the registrar, and demographic information is noted. Transcription errors can occur at this stage if the doctor's handwriting is less than legible, or as I like to tell the medical students, is crab coded. Each condition is then coded onto this form. However, when the coder selected the underlying cause of death, she chose a non-pregnancy related code despite coding it properly on line C, indicated there by the arrow. In general, misclassification of indirect deaths occurs because ICD-10 has different codes for medical conditions depending on whether the woman was recently pregnant. Only conditions with a code beginning with O, which represents the obstetric chapter, will get counted as a maternal death. Puerperal cardiomyopathy deaths, however, may get overcounted if doctors do not record the duration since birth, as many of these deaths occur after 6 weeks postpartum and should be coded as O96.1, not O90.3. I encourage all of you, especially from the larger territories, to pull medical certificates of known maternal deaths and check how they were coded. I will now look quickly at the epidemiology of maternal death and how this has changed in 30 years. Initial successes in reducing the total MMR in the 90s has plateaued since 2000. While direct rates continue to trend downward, indirect deaths steadily increased up to 2006 and has responded to our efforts since then. The leading causes of these indirect deaths are cardiovascular. The 1% of women with sickle cell disease exert a very strong influence on our maternal mortality rate, and their rate ranges somewhere between 500 and 700 per 100,000. Similar to the maternal mortality rate experienced in Africa and Asia. HIV/AIDS appeared in our population, in our antenatal population between 1998 and 2000, responded to PMTC initiatives. However, the uptick in 2010-2012, Mr. CMO, needs to be monitored. Increasing diabetic deaths since 2000 resulted in a policy to routinely screen obese women, and in the last triennium, no maternal deaths occurred. No diabetic maternal deaths occurred. Now, what are the reasons for some of these changes? If we look at census data over the last century, we'll note that fertility control programs, which began somewhere around the 1970s, have led to the first decline in 2011 in the under 15 age group since 1943, alongside the continued expansion in the reproductive age group. Compared to the elderly, in relative terms, both groups have doubled since 1970, but in absolute terms, the 15 to 49 age group increased by over 600,000, while the 65 plus age group increased by 120,000. This age group, the reproductive age group, is today's challenge, and we need to join forces with elderly advocates to focus preventive health investments on them to modify their lifestyle practices, as we've been talking about the NCDs, to dampen their future impact on the health sector. I'm glad I'm not going to be around when they get old. Despite the growth in the reproductive age group, births declined by 50% across all parity groups since 1980. Shifting childbearing from young, lower-risk women towards older mothers who now come to pregnancy obese, hypertensive, diabetic, and having heart disease, and these things explain the increasing incidence of indirect deaths. Antenatal care must therefore now change to cater for their combined obstetric and medical needs, and this needs to continue after they have delivered and make sure that they continue their medical care. Jamaica has the 4th highest rate of adolescent fertility in the region, and while this rate, shown in red, has declined, their mortality rate has been increasing, especially from abortive outcomes, and addressing the abortion problem in the region seems to be the biggest no-no in the world. But guess what? It's going to bite us. While mortality among periphery, shown in red, has trended downward, shown in green, has trended downward, the high parity mother in red has not disappeared, and her mortality rate has been rising lately, like that of the adolescents. Mortality among older women exceeds the national average, and we must equip our facilities to address the special needs of this age group, especially as we move beyond 2015. Let us now look at the uphill battle in the post-MDG agenda. A high-level panel of eminent persons were assembled to consider the post-2015 development agenda and have called for 5 transformative shifts to it. They recognize the need to address inequity in development, that interventions need to be sustained, that without jobs, economies cannot improve, and that institutions need to be accountable to the people that they serve. 7 strategic objectives are being considered to help forge the way toward ending preventable maternal mortality. The first 2 are cross-cutting issues spanning multiple agencies, while the other 5 focus on the health sector. In regions like ours, where rates are relatively low, we must identify the high-risk and hard-to-reach groups to ensure universal access to quality health care for all. Our range of reproductive health services must be better focused on the changing needs of this rapidly growing population. Reducing indirect mortality will require that health systems be upgraded to meet the complex needs of today's mothers, and we must monitor not only impact, but the processes of care and ensure accountability. For Jamaica, with an MMR of somewhere between 90 and 120, WHO suggests we work towards a ratio of 30 to 40 by 2030. The Latin American group, called GTR, however, felt that with only 12 countries in the region with rates above the regional average of 80, we should really be aiming for 25 per 100,000 by 2030. Now, geographical access is one form of inequity that we can easily measure in Jamaica. This chart shows that the only real improvement in outcome has occurred for women living in parishes with tertiary care, including ICUs. The middle columns are parishes where obstetricians are based, and the OB2 column, those services which were upgraded in the last 2 years. The final column are parishes where deliveries are attended by midwives and emergency C-sections provided by surgeons. No change in 20 years. Like Jamaica, Argentina's experience with indirect deaths, shown in yellow, which is a little difficult to see for Argentina, but it's similar, the Jamaican situation looks the same, mirrors ours, with indirect rates increasing, then turning down recently. Now, we have tried collaborating with physicians to jointly care these mothers, but this has met with very limited success. Medical outpatient clinics rarely occur on the same day as antenatal clinics, and women must bear the social and economic cost of repeat visits. As inpatients, they compete with cardiovascular and other patients for limited ICU beds. Another option is to train and equip obstetric teams to manage these women. We now have 2 fetal medical specialists at the University Hospital and 1 at Victoria Jubilee, but posts and sponsorship are needed to insert these skills into all of our referral hospitals. The European Union has supported a project to add high dependency units into the obstetric departments of our referral hospitals, but the skill mix needs to come along with the resources. We could improve the counting of our often invisible maternal deaths by implementing an updated regional medical certificate, and CARPHA is being called upon to promote it and monitor its adoption. This new MCCD should include a pregnancy checkbox which asks if potentially fertile woman was pregnant when she died. If she wasn't, it would ask to document the date her last pregnancy ended. With a little bit of arithmetic, we can classify deaths in this population as either definitely, positively, possibly, or not pregnancy related. I'm going to ask you when you go home to explore how your obstetric population has changed and whether anything different should be done to respond to this patient, to today's patient profile. Are you equipped, and are your at per year to 8 to 10 deaths? And is coming down to those numbers really feasible? With 1,700 perinatal deaths per year and babies much sexier for grabbing votes, they are easier to kiss, should we be documenting the poor survival of these women's orphans to make the case that fathers are not mothers and that the best mother is a living mother? Should we go back to where we began, by reinserting the M into child health, especially as the determinants of perinatal and maternal death are similar? So in summary, what we do not count has not happened. So please ensure that you are accounting for all your maternal deaths. I am willing to come and help you set up your surveillance system. However, the global actors want these deaths reflected in our vital database. Since 1996, we have been teaching physicians at Mona how to correctly complete a medical certificate. All your doctors need to be trained how to complete that certificates properly, and your coders need to be trained to correctly code these deaths. Because the numbers are small, the opportunities for experience are limited. I helped WHO put together this document which they published in 2012, the ICD-MM guidelines to assist in properly coding maternal deaths. And finally, as one hand can't clap, as we say in Jamaica, a woman don't get pregnant alone. Partner participation in women's decision making needs to be better understood as we move forward. And finally, we have to become better advocates for and on behalf of persons 15 to 49 years. We have to become better advocates for persons 15 to 49 years so that the face of maternal health looks more like the one on the right than that on the left. I'd like to thank my colleagues from the Ministry of Health who have embraced maternal mortality surveillance within their expanding portfolio of responsibilities. These girls would not be so beautiful if they did not have a mother. So let's give them a hand.
All right, ladies and gentlemen, I'd like to thank Professor McCaw-Binns for that excellent lecture. Perhaps the take-home message is that it takes two to become pregnant. But outside of that, the floor is now open for us to have a question or two.
Clear as mud.
I've seen some CMOs in the audience here, and so perhaps I could get some feedback as to what would they consider the quality of their death record, the death certificates. How confident are they about the quality of their death certificate? But I'll take your question first.
Thanks very much, Affette. I think this is a remarkable presentation that highlights an issue that we need to focus on. And as you correctly said, the McCaw-Binns is still struggling with the issue. And of course, the issue of the increasing numbers is quite remarkable too. That has happened after we introduced the revision based on some of your work, actually. Lots of, for example, none of the abortion-related deaths were reported in those 1991 figures. So that's one of the outcomes of revising the system, is that your figures will go up because you're finding more mothers, more pregnant women that report before. So that's one, the abortion-related deaths that are not reported, and for obvious reasons. Some countries do have some legislation to allow for termination of pregnancy. Some don't, and if it's criminal, then it's not reported as such. The other issue is the classification of the indirect causes. And it doesn't mean because someone is HIV positive or death is not a maternal death. We've had many mothers now who are on repeat pregnancies, third and fourth pregnancy since they know that they're HIV positive. The last few review, we have to actually change the classification from indirect to direct because the woman bled to death. She didn't die because she was HIV positive. She bled to death like many other women. And of course, hemorrhage is accounted for in a lot of, more than 50% of the cases were due. So the fact about having access to facilities that can perform cesarean section and do blood transfusions are so critical. These are the 9 extended EMOC functions that any working center should actually provide if they are considered comprehensive. The last one is malaria-related deaths in Guyana too, because that again was never included.
Which kind?
Malaria-related deaths in others. And as you know, malaria-complicated pregnancies lead to several unfortunate outcomes, including stillbirths, high stillbirth rates among mothers. And obviously, with the backdrop of high levels of anemia in many of these communities, due to maybe nutrition, but also complicated by intestinal infection. I think that's another area that countries that do have malaria, Guyana, Suriname, a few others, like Haiti, must be considered. They were not counted in the past. So one of the caution is that as you do this revision and as you put these new measures in place, your rates will go up, and it will be a tough job for us as technical people to defend that in the political arena with ministers and so on. And we'll always be under pressure to change back to some original format. But I think we are strong enough. We know the value of women in our society, and we're doing this for the future. So I really thank you for this presentation, and look forward to us moving this to the third or fourth year.
Right. There are a couple of things that you said that I'd like to comment on for the benefit of the audience. There's like an all-time saying, seek and ye shall find. Once you start looking, you will start to find them. But you need to be honest with yourselves and say that you weren't documenting them properly in the first place. The second thing is the fact that women have medical conditions. It doesn't mean that they can't die from direct complications of pregnancy. And so even if they are HIV positive, their likelihood of puerperal sepsis increases, and they may actually die from puerperal sepsis. What we are documenting as HIV deaths are women who died from complications of HIV/AIDS. And so we have to be careful in the classification and how we account for these deaths, that what we are calling HIV/AIDS is actually HIV/AIDS in pregnancy and not an HIV positive woman who has died from a hemorrhage or eclampsia or something else. And this is the same problem even among the sicklers. We get a high incidence of preeclampsia and those kind of complications among persons with sickle cell disease. My colleagues at UA would want to, cut my foot when I tell them that every woman with sickle cell disease needs to deliver in a tertiary care facility, because they are fine today and they go downhill tomorrow. And so, you may have good success with them, but they need to be in tertiary facilities. And we need to understand what are some of the challenges of these patients. And sometimes the mothers will do fine and the babies need to be near a ventilator also, because of how things may change rapidly. So I'm grateful to hear that things are happening, but we have to be willing and brave enough to take on the challenge. But we have to look, because if you never look, you'll never find.
Dr. Pate.
Ernest Pate, Affette, thanks for a really excellent presentation. And I have to agree with Shandia, colleague from Guyana, that as you start looking, those figures are going to go up, both from the maternal side, but also from the perinatal and neonatal side. And I think you'll have an even bigger problem in reducing those numbers within the Caribbean. We did a rough estimate about 3 years ago in the Caribbean countries, looking at some compliance with ICD-10. And I must say, you're very aware that in many of the countries, there isn't even birth weight on that certification. And if you don't have the birth weight when the person comes to do the coding, to say whether this was a viable birth or not, they're in a quandary. And it's on both sides, because sometimes the birth weight, when you do a retrospective look, is less than 500 grams under ICD-10, where it says 500 grams compiled, length of 25 centimeters, a heart rate of 60 and above with signs of respiration. And in fact, in many of our countries, although this is what the governments have signed on to as their standard, we looked at 13 countries. 6 of those countries in the region have in actual fact not changed that law that they have signed, but they have made cabinet submissions that allow them not to record. And I think that that's such an ingenious way of fudging the figures, because they make a cabinet submission which then says that if the baby is under 999 grams, they don't necessarily have to record this. And in fact, in many of our countries, a lot of these kids who deliver and very low birth weight don't get into the records at all.
Institutions like CARPHA say this is the standard birth certificate Jamaica is going to be, and all of the countries are going to be evaluated for implementing a birth certificate that documents gestation and birth weight on the record because we cannot report to WHO what our birth weight specific mortality rate for the region is because we never got the data, right? There were some of the, I mean, we looked at everything. It's not just death. We looked at the stillbirths also. I had 350-gram babies because I went back to the records. I had 350-gram babies whose births were registered, right? So, you know, it goes both ways. The only thing with the perinatal deaths, because the underreporting is so high, the little brata that get in for these low birth, underweight babies makes up for what don't get counted at the top end. But I mean, we have to fix the system. And I think governments respond to some external agencies saying do it. It's something about the whole mass now. We have to have somebody cracking the whip over our back. So if CARPHA can be the whip cracker, crack it. Put together a revised standard death certificate, birth certificate, and I would like to see, from putting on my perinatologist hat now, perinatal epidemiologist hat now, that there's a separate medical certificate for the perinatal deaths up to 28 days, stillbirths up to 28 days, so you can document the maternal contribution to the deaths of these stillborns and neonates. But it has to be done, and it has to come from without, because alone, getting the governments to push it alone is never going to happen.
Good morning, I'm Dr. Sanders from the Bahamas. Thank you for an excellent presentation. I agree, death certificates are one of the most difficult things to fill out. And I think, as you said, that there should be some standardized form and even instructions. And I think, as a young doctor coming up, I think that probably even implementing it in our training in medical schools, how to fill out the certificates properly, may also help in terms of reducing the errors moving forward with the certificates. But nice to think of an excellent presentation.
I think it needs to be in the curriculum in all of the medical schools. We have been doing it at Mona, but it's not a standard part of the curriculum.
Hi, Tara Thompson from Yale University, Jamaica originally. Thank you very much for an excellent presentation. I wondered if we could transition the conversation a little bit and speak to the steps, if any, that have been taken to examine this association between the presence of a tertiary institution and maternal mortality in Jamaica. Has anything been done policy-wise?
What do you mean by a tertiary institution?
So the presence, having a midwife versus an OB.
So there's the data.
Right, have any conversations happened?
We are in the, as I said in the presentation, oops. As I said in the conversation, in the discussion, we are now you have to try different things. We tried to get the medical and the obstetric team to work together, and that hasn't worked. So we are now trying to say that since we can't line up behind the GSW them and the men with their heart attack for the one ICU bed, that we need to at least put some high dependency units where we can get women who need short-term ventilatory support after postpartum hemorrhage on a ventilator, and the knock-on benefit to her baby will also assist us. So we have gotten some EU funding to put in these OB hospitals high dependency units, but we also need the quality staff to be able to manage those resources properly. So we are working on it. I mean, you can't fix everything everywhere because we're poor. So it's the priorities. How do you establish the priorities and where you're going to start doing them? And we have to try to be creative. So we tried to be creative and it's not working, so we're moving on to the next level. But I think we're working on it.
Can I just take the chair's prerogative and pose a question? To what extent, in your research and experience over the years, there's differences in laws relating to abortion across the Caribbean contribute to maternal mortality, excess maternal mortality?
Well, something wonderful happened in Jamaica in 2007. Mr. Prostal was licensed for obstetric use. And Mr. Prostal, which is one of these drugs that were used for treating gastric problems that is also an abortifacient. And we have been using it to do things like induce labor, and it got licensed for obstetric use. And since Mr. Prostal was licensed for obstetric use, I have had no nasty abortions where a woman's uterus gets chopped up. I've had no more teenage suicides among pregnant girls. So it is on the street. We don't want to take on the church because the church is a very strong element in the Caribbean. Some places have managed to take them on, Barbados, Guyana, but the rest of us can't take them on. And so we have to find ways around these issues. I have a nice little card that we put together when we did the hypertension guidelines with 4 or 5 pictures of potential prodromal signs of eclampsia. And I want a card like that now for the complications of abortion. Bleeding, abdominal pain, fever, and ask the people that's selling the stuff either in their private practices but also on the street to put the card in the envelope and say when you have these signs and symptoms, please go to hospital. Because managing the complications of abortion from Mr. Prostal is much easier than managing the complications of a D&C gone wrong. So that is my issue. The problem we have had with the increase in abortive outcomes is that when women come to hospital and say, I have tried to terminate a pregnancy, the assumption is that she have an infection and she gets antibiotic and painkiller and gets sent home. And a lot of these cases have actually been ectopic pregnancies. Nobody did a pregnancy test to make sure that she was no longer still pregnant, and nobody did the investigation looking at her, doing an ultrasound to make sure that there weren't any retained products of conception in the uterus still. So the stigma associated with trying to terminate a pregnancy privately when the laws don't enable it is an issue. Then we have had some very zealous police that have gone after physicians who have tried to help out situations and terminate pregnancies in very young children and they have been arrested. So, you know, it is hard. I mean, I got a hold of the policewoman. Me and she had a very serious time.
And with that, ladies and gentlemen, I would like to bring this session to a close and Professor McCaw-Binns for an excellent presentation. So at this time, we will break out into concurrent sessions and we will continue in this hall, room hall AB, looking at the session on non-communicable disease. There's a concurrent session on HIV, which is ongoing now when we speak in room C. For those of you who would like to attend that session, you now have an opportunity to exit without me feeling bad.